we have a very eminent personality here with us to deal with the session, Dr. Athul Joseph Manuel. So let me give a brief introduction of Dr. So Dr. Athul Joseph Manuel is currently working as a medical officer at Palliative Care Department of General Hospital, Ernakulam at Kerala. And he's currently coordinating the COVID-related activities of Ernakulam district. And he also worked at Amrita Institute of Medical Sciences and Government Medical College at Ernakulam in the Department of Palliative Care. So he's the nodal officer of Ernakulam District Flood 2018 and worked in NIPA's control team of 2019. So he would be obviously discussing the relevance of palliative care during a crisis. And currently we have been facing crisis for the past 1.5 years. And also his team has done, which is been definitely highlighted across the world. So, sir, we are very privileged and very happy to be with you in the session. So I welcome you once again, sir. And our agenda is till 4:15, we'll be having the faculty presentation, and after that, we'll be having a discussion followed by this. So I welcome you once again, sir, and please over to you.
Thank you, Narishma. So, good afternoon, everyone. I guess everyone is on video, all the videos off. So, good afternoon, everyone. So, we are here today regarding the humanitarian activities in terms of palliative care. And I would like to mention, first of all, that I am not a theoretical person on this field, just that I happen to be in some right places where humanitarian activities were needed. Uh, since I'm working in control room, once in a while I might be getting calls. 1 second, I'll pause. Sorry. So as I was talking, I've not done any theory part in terms of humanitarian crisis or disaster management. Just that happen to be in some places or some situations uh, for the past 3 years in terms of humanitarian crisis. And what I would like to highlight is the background of palliative care, which has helped me in working in these fields, because the concept of palliative care of the patient-centered approach, along with the family and the empathy part, that has really been a driving force in combating almost all the disasters. So, with the minimal expertise of in disaster for the past 3 years, the first disaster that we struck was with the floods in Kerala. Everyone is well known with the floods that were affected in Kerala back in 2018. And obviously, after that, before that, we had a Nipah outbreak, which was in the northern part of Kerala, Calicut. And the second Nipah outbreak was here again in our district of Ernakulam. I am situated in the central part of Kerala. So again, we had a Nipah outbreak here, and it was like an auto mode where all the people who came together during the flood again were called upon or voluntarily came up when the next disaster hit. Then came the third and the present disaster, which is COVID. So what I would do is I have not created a presentation as a whole, but I'll be more talking in terms of my personal experiences, as well as I'll just go through two small PPTs, one in terms of COVID and one in terms of flood. So initially I'll go with the COVID scenario, where we all know what COVID is. There is no need to explain what COVID is. And regarding palliative care, as I understand, this is the 10th session, so everyone would have got the gist of what palliative care is. So I would just go through my presentation in terms of COVID. So this is again the integral part of any aspect that is getting touching with palliative care, which is that which we always emphasize in palliative care. You would have heard or studied, and we even talked about this whole introduction of palliative care or the concept of palliative care. And in that, so we have a in here we have a two tiers of palliative care, which is primary and secondary. And in terms of uh, home-based care, so this is what I would like to emphasize in terms of COVID. So we all know when COVID struck back in February. I still remember the first wave of COVID when the initial spread of COVID happened in China in January, and by December, January, the people are talking about COVID in China, then again in Italy. That's when we had a palliative conference in Assam. So when I would be talking about my personal experience, again with the experience of having worked in two disaster control rooms, we were again called upon for the third disaster control room for COVID back in February, January mid. So by the mid of January, we all assembled in a control room, and that is when our parity conference was happening as always on the second week of February in Assam. So I was called upon to present on the humanitarian aspects of the flood in COVID, and I still remember that since we had few students who came from Wuhan, and again all the things were getting controlled. Still, we had that COVID in mind, and I was traveling in the flight, and I was on with mask and sanitizer, while the whole rest of India was actually protected from COVID at that point. Then by around March was when the sprouting happened and the initial cases started in Kerala. So on March, by around March 15th, we had the idea of starting a telemedicine unit. So initially, when I talk about COVID, I will just pause my sharing. So when I talk about COVID, by it was a progressive learning aspect from COVID, and in those days, initially, when we started off, we had no clue regarding what COVID is and how it's going to be. Later on, now we have come into that aspect of home-based care, where we understood that most number of people could be managed at home. And on terms of COVID, how the COVID took over the whole world was basically on toppling down the healthcare system. So everywhere the major issue was the overrunning of healthcare system and the overriding where people would be stranded at homes or in the streets without getting care. So on that aspect itself, uh, we were quite vigilant from the beginning, and we thought of having a good patient management system in the sense so that it doesn't get over us, or we were getting stories, we had learning points from Italy and all that. People were unwantedly admitted, and when the real person who needed a bed came in, he didn't have a bed to support them. So these learning points were taken care of, and with the at least my palliative background as well as my senior Dr. Matthews, who is the district program manager of NHM of Ernakulam district. He is also a veteran in palliative care. So we were discussing on how to manage things. That's when I called up Rajawal sir. So sir and me, while we were talking, it was during the conversation that it actually hit us that on those days we were talking about the probability of survival, and it was the percentages were coming in, and it was like 85% would be 50% would be asymptomatic. Out of the rest of the 50, around 40, around 35% will be only having mild symptoms. Only 15% would be needing hospital care. Out of the 15, only 5% will be needing ICU care, and out of that, around 1% will succumb to death. And we were talking about the vulnerable population, and when we were just discussing, it struck both of us that when we talk about vulnerable population, those are our patients whom we take care of, especially in palliative care. Though we emphasize on palliative care to be started off early, and we have been striving for that. But still, we know that due to practical issues and due to lack of awareness regarding palliative care, still we are considered to be people who look after patients during the end of days. So, especially coming into vulnerable category age, then the kind of diseases which are described under the vulnerable category, our patients are the ones who are going to die. So, uh, it struck us very hard. And on that day, we discussed with the palliative care team in Ernakulam, and we came up with a Pali-COVID group of doctors who discussed on how to take care of or how to cater to the whole uh, situation where our patients will be in the most difficult place, because all kind of emotional trauma was going on. We were getting news from everywhere that people are dying without getting care. So, but there was a light under in the end of the tunnel, seeking that at this point at least people might, or the awareness of palliative care might glow up, because we have to save our patients from the misery that is going to come upon, especially during breathlessness and the faulty treatment of using ICU unnecessarily. So then came the point where if we can save our patients who might not, the futility of medical treatment is already written upon them, then at least we could prove to the world that there is a better way of taking care of these patients than putting them in an ICU. And in terms of patient management or the uh, situation of COVID, number of beds were very precious. So what we kept on the table for them was, if you could take care of patients like this, then you can save many of the ICU beds, and unnecessary utilization of ICU beds won't be happening. So that was a bait that we gave, and actually it took a lot of time, but to make them understand. But still, we were able to produce a document in terms of Pali COVID. I guess you would have already seen it in Pallium India's website and all. We brought up with a Pali COVID document with the help of all the doctors in the Ernakulam district as well as Pallium India, and n number of Pali COVID sessions were taken by Pallium India and the ECHO group, and to spread awareness on how to cater to palliative care patients, especially in the COVID times. So this document was accepted by WHO South Asia, and it was well recognized. So in these terms, it came, and one of the major issues that everyone was asking is, if a bed-bound patient gets COVID, how would we be treating them? Because on those days, everyone was taken into an institution. Then came the home-based care system. Home-based care system, I guess by end of July, August, home-based system was brought in, and the asymptomatic patients or the mild symptoms patients could be taken at home. And palliative care, we what we consider the cornerstone of palliative care is home-based care, where home-based care doesn't just mean to keep everyone at home, but keeping people at their own homes with proper care in terms of both physical, psychological, social, and spiritual support. So this was given through a telemedicine system. So we were the ones who started off telemedicine system in our district back in March 15th, where we started off with 5 doctors, and now it has catered to around 2 lakh patients, and it has been running well, and it helped patients to be at home. So initially, during the phase, we had more number of patients who were on quarantine. Then quarantine changed into positive patients being at home. And patients being at home, what we found is, by giving a good support over the phone, we could help them be at home. Help them be at home in terms of administrative part, you can take it as relieving more beds from hospital. And in terms of our palliative care aspect or the care aspect, we could take it that people could be safely at home, ensuring that in case of an emergency, there's a system to back them up to be taken to a hospital. So the patient management system was built in such a way that we tracked all the beds in our district, including both private and government sector, and all the shifting was done through us. Uh, one second, sorry. sorry, again getting calls in terms of. So in that way, we could establish a home care system where the major backup was the shifting system as well as the telemedicine support. So usually in palliative care, we tell low tech and high touch, but
Excuse me, sir. Sir, I would like to ask you a question. Have you forgot to or share the screen or?
I think screen share stopped. Sorry, sorry.
Okay,
Now
thank
is
you,
it?
sir. Sir, can
So
you please put that in a full screen mode?
full screen. There's some. Yeah, now it's
Yeah,
okay.
thank you, sir. Thank you.
So then that once that home-based care was started, the advisories were given through phone, and as I was talking in palliative care, usually we talk about low tech and high touch. But through COVID, it has taught us that we need to be high in tech as well as high in touch. So through technology, we were having giving advisory over the phones and giving the backup for the nurses in our field. And our nurses were linked with so much to the community that they could be playing a role in safeguarding the patient. So initially, we had a lot of information, education, and communication going out in terms of COVID. Even still, we are talking the same thing what we were talking 1.5 years back regarding social distancing or masking and sanitization. So what we did at that point is we would have learned about the Kerala palliative care system, where we have a community nurse, at least minimum one community nurse from the government side, and a lot of NGOs working in the field. So we called up all the community nurses, and all we started educating them regarding the advisory that needs to be given to a patient with a home with having a homeborn patient. So this information was given personally, though the IEC was going on in terms of visual media, audio media, and all the platforms. This very much gave them a confidence that the follow-up is not reduced, because initially the main hindrance that we had is all the home cares were paused because we didn't know what to do, how to go forward, whether the providing home care with the usual universal precautions were enough. Later, we came up to the point and we understood virus and we understood the type of spread of the virus, and then we were able to advocate home care on with having universal precautions. But initially, we had paused all the home care, and thereby many of the care was disrupted. So only emergency cares or essential cares were continued. Rest all the advisories were done by the phone. The when we talk about patients who are at home and who are registered in palliative care on palliative care, they are very well communicated or very much conversed with their community nurse. So I what we usually tell is, even if I write a medicine, for example, a phobic medicine like morphine, if I write a medicine, unless the community nurse approves or in terms of gives the patient a consent that you can have, the patient won't have. That's the kind of trust they have in this community nurse. So this community nurse would be calling the up on fortnightly or on a regular interval, ensuring them and their family of the precautions that need to be taken. And in this way, the concept of home-based care was more empowered. And also later, when it came uh, to quarantine patients or positive patients, we had lot of homes which had uh, long-term patients or homeborn patients, or you could classify as palliative care patients, who had quarantined people at home or someone would have got positive. So testing these patients who are homeborn again became a big issue. And again, our palliative care nurses and everyone rose up to the occasion, and they went with universal precautions to homes doing the testing and triaging, and even in terms of if the test came out to be positive, discussing on the long-term goals of what to be taken, whether the patient needs to be shifted or not in terms of if the patient becomes more sick. And even later on, during once we started and we learned COVID, we were able to provide with oxygen concentrators at home, and we were able to start early steroids. And one of the wonders was that uh, what would I like to say is like usually people who have been rejected by the healthcare community was taken care mostly, and people survived as well as had a good uh, symptom management by early focusing on them and giving early treatment at home. So we had nurses who were trained in giving injections at home, and even we had oral tablets of steroids available, Rexona and various other tablets. And we had, if the oxygen was needed, we were providing oxygen concentrators, oxygen cylinders at home. This way, we were able to cater to many of the needs at home. In between that one instance that I would like to come up with is one fine day we got a call in our uh, call center that old age home, almost like a hospice nearby, was affected by COVID. So the only information that we got is there are around 120 inmates and it's catered by nuns, and three of the nuns have become positive, and surveillance team had gone there and they did the testing. Around 15 of the patients have become positive inmates. So I still remember the day, and me and my friend, we personally went there. Those days we were not sure who is positive, who is negative. So I was just wearing an N95 mask, and we entered the institution. We had our hands held back. We didn't touch anyway. We just inspected the place, and we were initially thinking of segregating. Then we came to know that everyone is when we entered inside. Actually, we got to know the real picture that everyone is mingled, and even though if we segregate now, many of them are bound to become positive. So we made that into a first line treatment center. We didn't shift any patients from there, and we categorized those patients in terms of utility of ICU care. And there were few patients who were admitted just because of the psychiatric illness. So we had a doctor placed there, two nurses, and they would do a daily rounds in PP. We had a donning and doffing area set up in the same institution, and they would stay outside and get inside the facility, do the rounds, uh, do proper triaging, only shift any patient who needs to be given an active treatment in terms of ICU care. Rest of the medicines like steroids and morphine and midazolam and all the medications were provided in the center, even with oxygen concentrators. And actually, out of the 120, only four deaths happened that month. And since it was a hospice it was a regular thing of around 4 to 5 deaths happening in a month. Then we could manage that situation in a very profound way, and that gave us confidence. As I told, regarding COVID, every day a new guideline comes, a new perspective comes. And by those times, we were making our own perspectives for how to deal with this pandemic. So again, we segregated our care into aerosol generating care and care as well as non-aerosol. So initially, home-based care was for contacts. Later, for any home care, actually this PPT was made back then. Sorry, I couldn't make a PPT now. But now what we are doing is for any home-based care, for any home care, we are not disrupted. We are doing all the home cares for all the patients. The only thing is the kind of personal protection gear that they need that we are providing in terms of these two types of care, all aerosol generating as well as non-aerosol generating. And full PP doesn't mean that full coverall. Only a gown is enough. That's what we have again learned from experience. Because coverall came in terms of NIPA and also regarding a closed aerosol generating procedure, closed room. Again, what we have found is actually a proper face shield with a three-layer mask or a N95 mask is actually what is bare minimum needed to combat COVID, even for a COVID positive patient. So for aerosol generating, again, we were giving head caps as well as disposable gowns, not coverall. And telemedicine units, as I was talking earlier, this gave us a lot of backup. Especially now we are catering to COVID positive patients at home. And when our nurses go there, we provide them with a telemedicine system where they could talk to a doctor and what treatment should be given and what examination should be done might be decided earlier. Then the nurse goes there, nurse does the examination, again contacts the doctor because we always know that number of doctors available are always in shortage, especially in palliative care. So nurses are our backbone in terms of giving care, and they would be providing both physical and psychological support. Because just through telemedicine, it won't be enough. So even our nurses are well trained in that. So they were providing care, and we have n number of, and we are planning to bring out a study on the care that we were able to provide in life. We are able to save in terms of giving care at home. So reverse quarantine again, which is easy to say reverse quarantine, but it was not that easy to implement in the field because, especially when you talk about reverse quarantining a patient who is homebound, you can't close a patient inside a room. He needs psychological support, he needs his social support, he needs physical support. So what we're doing is it was basically mainly through the phone that we were giving reverse quarantine in terms of advice. And again, teaching their family on what all care they need to take while they go out, because again lockdown or putting everyone inside a home is never a solution for such a pandemic. And in terms of that, we gave regular advices on to the household of people what to do when they go out and how to take care of them when they come in. So what simple theory that we were talking giving them was, there are two ways that you can bring COVID to your home. One is you take COVID inside and bring it here and give it to your family. There is nothing much you can do. So if you have to stop having COVID inside your body, you have to take care of yourself when you go out. So proper mask and proper social distancing and proper sanitation was the only way out. So take care of yourself so that you don't bring COVID inside your home. And if you have taken care of yourself, there are chances that there might be some you have been exposed to COVID outside, and on your mask, on your dress, there might be some virus. So how to take care of that as well? When you come home, how to dispose your mask, how to get into your washroom directly, soak your dress, have clean bath, and come out and then interact with your vulnerable population at all. Because you can never stop interaction. Interaction leads to larger psychological distress than even COVID being hit at home. So again, this was imposed on at homes. Then we had a separate call center just to take care of all the geriatric population. We had all the old age homes under strict surveillance in terms of admitting new patients. And uh, this was another innovation that we came up during COVID, which was a community pharmacy. Community pharmacy is a system where we know that usually long-term people on long-term medicines, they are the ones who have been disrupted during a crisis. Especially, we learned that during a flood time. I would be coming into flood later. So on that aspect, we from the initial days, as I said, everything is a learning procedure. So all this came up during the first few months. During March itself, we came up with this community pharmacy where we were providing medicines to all the palliative care patients as well as other people who are in need of medicine. We had a lot of young volunteers who would take the medicine and reach their homes. And this was done through LSTA funding as well as public funding, and we were getting lots of funds from everywhere. And we had many delivery boys. It was almost like a Swiggy kind of thing, where the request would come, we would check on the request, it would be verified by the community nurse, and the medicine would be delivered at the homestay. So triaging again, this was the key in terms of controlling COVID, because unless you do proper triaging, beds will be unwantedly occupied. So triaging was not in just terms of giving care on what type of care you want. For example, at the moment we are just categorizing beds as oxygen beds, non-oxygen beds. In the oxygen bed, whether you need a supportive uh, device like in an ICU. So these are the three types of beds that we have. So when you get a patient, whether through phone or through an OPD, we basically triage them regarding what type of bed they want. And if the futility of an ICU is studied upon earlier itself, we counsel them regarding quality of care and proper utilization of resources, and as well as the importance of palliative care. Some patients won't be registered early in palliative care. And what we found was, as we have been taught in palliative care, proper communication. Communication was the key. How you put forward. You can put forward it as I don't have an ICU bed, you are not given an ICU bed. Or you even put forward that I have kept reserved our ICU beds for a younger population. I can't afford to give this geriatric person a bed. Or even you could put forward that in when you think about that person, that 90-year-old female, it is best to give her a care where she deserves and the care that she wants. And actually, what we found with proper communication skills, we were able to convey that message, and we were able to properly use our resources as well as give care in a much better way. So this was a Pali-COVID Kerala that I was talking about in terms of the Pali-COVID document that came in with respect to COVID-19 and palliative care, which addressed all the issues from symptom management, psychological issues, triaging, as well as how to give end-of-life care. Then at the moment, what we have is vaccination. Just before going into what vaccination, I would like to bring upon a statement that when you talk about a pandemic, it's not just a healthcare issue, it's a public issue. And when you talk about public issue has a health aspect, administrative aspect, political aspect, all the aspects coming in. So when the initial phase was vaccination, it needs to be given to the vulnerable population. But again, acceptance of vaccine was another major hurdle that we were facing. And because of the acceptance of vaccine was questioned, we were hesitant to give the vaccine to a vulnerable population, because if a patient dies after taking vaccine, it might be a natural death, which was an impending death, but it will always be attributed to a vaccine. And hence, we had to withhold vaccine to be given to a vulnerable population initially. But later, once the efficacy of vaccine was established within the community, not in the healthcare community, within the general community, once the efficacy of vaccine was established, now we have started giving vaccines at home to the vulnerable population who even are facing impending death. Now we have started home-based vaccination, and it has been a huge success, and it has been going forward very well. So I would like to emphasize the fact that when you think about a pandemic, never of it as a healthcare issue. Because if you think of healthcare issue, you would advocate a lockdown. But when you think about lockdown, you are actually burdening people more than a healthcare issue. So always think of a pandemic or a disaster as a public issue, though it might have a large component of healthcare accepted into it. But then that is the way forward in what we have learned from the field. So as I said earlier, I have never done a course in emergency management. The only thing what we have in my backup is the knowledge from palliative care and the field experience. So then what we had is the accessibility of getting vaccines, which has been well studied and the accessibility issues in terms of delivering vaccines. Again, thankfully in Kerala, we have a well spread palliative care system, both in government and NGOs and private. So through the system, now we are delivering vaccines at home. And again, monitoring, since we have a usual monitoring system in palliative care, the whole vaccination process is going on. And even from the field on vaccination, what I would vouch is the efficacy of vaccine in terms of not a patient being saved with the vaccine. I can guarantee, because when we work in control room, we are always vigilant on what is happening. So during the surge, the present surge that we had, I still remember, like from April 2nd to third week till May, and I don't remember any day what happened, because it was a 24 hours maddening days. And there were times where we thought that we lost it all. and we might not be able to contain. So those days, what we found is we had in our my district alone, where we had around 33 lakh population. What we were monitoring was daily around we were shifting around 200 to 250 patients in terms of the Disney alone. Otherwise, we were shifting around 600 patients per day. But just looking at the Disney, we had around 200 to 250 patients shifted daily because of their breathlessness. And we were taking the vaccination status. And I would like to put forward or declare that we almost had no one who had taken two doses of vaccine. And out of the 200, there might be around 5 to 8 patients who would have taken first dose of vaccine. Rest all the patients are people who had not taken vaccine. So, with that field experience, I would like to encourage everyone to take vaccines or get anyone you know vaccinated to succumb the disease, because never think of we can wipe out COVID. The only thing that we fear from COVID is post-COVID symptoms as well as death. And both of these can be minimized with vaccination. And that is the only way forward now. So, in terms of COVID, I like to advocate on getting vaccinated. So, please stay together while maintaining social distancing, which we are now experts, I guess, so that we can tame COVID. We can never contain COVID. So, this is my experience in terms of COVID. And COVID being a well known pandemic now, and we would like to call it as a celebrity virus because it has gained a lot of attention. And what I would like to say is never give it too much attention, because it might take away all our thoughts, and it might even narrow our thinking process into just thinking about COVID. But we, from the day one, what we had in mind is our all our non-COVID activities should be continued, because COVID can only take away 1% of the people who have been affected by COVID, but rest of the all the diseases are still pertaining in this world, and all of it should be addressed. So we had a parallel system for COVID right from March. We tried to minimize getting people shutting down hospitals in terms of just for COVID. Though during the second surge, we had to do it for 2 weeks, but rest of the time we had our non-COVID system well established and well flowing. So that is one of the things we should never get carried away with such a celebrity virus. And what I would go, because yeah, again, since it comes personally, the time flies, and I would like to straight away go to our flood experience. So when it comes to flood, it's a more personal experience rather than COVID, because COVID is a personal experience for everyone, but for flood, it was a personal experience for few like me, because I live in a island which is covered by water on all four sides, and the river that flows through our boundaries are called Periyar, and Periyar was the river which was overflown in the central part of Kerala. So my village was fully drowned in flood, and I guess we had 100% evacuation from my village. So I'd like to go directly into flood. Are there any comments or queries till now, or should we proceed? Because I don't want to be monotonous in terms of.
Dear participants, if you have any queries, kindly ask or comment in the chat box.
Shall I continue?
Yeah, sure, sir.
Yes. So medical relief during floods. So this was a presentation I did last year for the palliative conference. Again, as I started off with flood, it's a very personal thing that happened. And all the pictures that you can see in this presentation are either personally taken or given to me firsthand by my colleagues or friends. So again, this is the third era we had I have been told by my parents that we had a very bad floods in Kerala back in 1920, around 100 years ago. And in 1961, they had a small flood. Again, they had to be evacuated from homes. And this was this time. So this was the photos that I took. The photo above was taken on the on August 15, around morning 11:30, and the photo below is taken from the same backyard around the time of 3:30. So you could see how the water was getting inside. It was not the flow, but the a small island being drenched out. And this is my dining room after the floods. After I got home, this is what I saw. So we had a very bad situation back then. We had almost 44 rivers overflown. All our dams, close to 30 dams, were all opened up overnight. And we had in our western Ghats, which you call the beauty of Kerala, was the landslides were happening, and we have 14 districts in Kerala, out of which 12 were affected with COVID. There were millions evacuated, and close to 500 deaths were reported during the floods. And we had a lot of camps. We had numerous number of camps. We had a large camp near my home, which catered around 10,000 people. So when the flood hit us, it hit us from 15th, started around 10th in a small way. Around 15th, it hit the whole state. And I still remember it was by around 19th that the ingrowing flood stopped and became stagnant. So till then, it was a rescue operation. What you can see on the left side is a doctor sitting in a Taurus, and I was the one who was in the control room sending out Taurus. So initially, from 15th to 18th, I joined the control room 18th evening because 15th, 16th, 17th, as I remember, I was rescuing my own family. So 15th, we got out of our home at around 6:37, and it was hard to convince my parents to come out because everyone was under the impression we have seen many floods, so it won't bother us much. But again, I had to persuade my parents, and they even got scared when the electricity and the network issues were happening with the phones. So I had to rescue my parents in a vehicle, uh, in the first gear. I still remember. I can't put it on second gear because if I put it on second gear, my vehicle will be drenched in water. So I rescued them, took them to my aunt's place. The next day I came to know that my aunt's house also might get flooded. So I again had to rescue them from there and them to a safer place. Once they were I made sure that they are in a safer place. I went to the control room, and it was havoc. Havoc in the sense calls were happening within those 2 days itself of people being stranded on the first floor. The ground floor is fully flooded. There were pregnant women. And one instance that I would like to highlight is I had a we had a church which was completely crumbled because of the flood, and 8 people got below it and died. And that was the only high place in that village that most of the villagers are standing on top of that church. So many of them are family relatives of the people who have died and who are still under that church. So it was a very emotional point there, and we had to give them medical help. So the Navy came in and the Fire Force came in, the Air Force came in. So the helicopter was going, but helicopter won't be able to fly after 5 p.m. So first day our rescue mission was withheld because of the light. Next day early morning, my friends and me and everyone came together to one doctor belonging to that area, flew from Qatar. He came. He and the one thing I would like to highlight is the people coming together during a crisis. That is a marvelous and joyful thing to see even during such a disaster. We had help flowing from everywhere, and the first helicopter flew there. And at the same time, there was another island that was tension. You can see on the left side that is a middle is the navy person on the white t-shirt, and the on the left picture, what you can see is Dr. Samin and Dr. Uh, I forgot her name. It's his wife. Both of them went on a helicopter journey and they were stranded there because helicopter couldn't fly during the night. They stayed there, provided medical help, and came next day. And on the right side, you could see two pretty ladies. They were the ones who scared the hell out of me because morning they came. They told me, sir, we are willing to go anywhere. So I sent them to a safe place, but their medical camp was easily over there. And people from there took these two doctors to another island across the high flowing river. And I got a call from one of the ladies' husband by evening asking for his wife, and I couldn't locate them at that point. The evening, these two wonderful ladies came to me and gave me chocolates, telling me that it was a wonderful experience. So, and it's impossible to come in words of how they were acting during those days. And I had many doctors who we respectfully think of as senior doctors, morning coming in their tracksuits and t-shirts and with their backpacks and telling me, Athul, tell me where to go. We are ready to go anywhere. So it was a very situation where not just doctors, nurses, friends, family, everyone, all the people. I still remember it was flooded with food. All the bakeries and all the food productions were completely given free for everyone. It was a just a wonderful experience to see everyone coming together. Even post COVID, we had a rehabilitation done by Indian Medical Association, which was a remarkable thing in terms of rehabilitation, where all the medical camps, usually a medical camp would be a single day event, but this one was on all the worst flood affected places, where all the follow up was done and their care was taken care for 1 year. Because one of our seniors told me that for next 1 year they should not suffer financially or psychologically because of an healthcare issue. So, and we were able to do that. And then once the flood started receding, then came the sanitation part as well as leptospirosis and clean drinking water. And this was the tagline. Everyone came together, and it was a special feeling to be able to be a part of it. And this was the control room that we were working with. We had all the departments inside a room, and if I wanted to send a vehicle to a remote place, all I had to do is ask the collector for that. Collector would give me a sanction. I would go to the motor vehicle department. The vehicle would be ready. The route map will be ready by the police, and it was a wonderful experience to be working there. And this was a healthcare control room that was set up similar like COVID. All the doctors came in. What you can see in the background is all medicine, and what you can see in the blue color is all the medicines that we came, all the support that we got had to be streamlined. We had around 20 to 30 pharmacists working 24 hours taking care of what all the necessary medicines that are needed so that it could be delivered. And all across Kerala, it was delivered from our district. And HR was coming in, help was coming in, but we had to streamline. I still remember two ladies who came from Tata Institute of Social Science. I thought there was, since they're coming from social science background, I thought they were psychological students. But it was only after they stayed with me for 3 weeks, just only during the last days that I came to know that they were in livelihood and I could send them to a place called Cheyandamangalam, which is having a handloom industry which was fully affected by flood and their livelihood was affected. So all this came in. Then the palliative care aspect. especially when you think about flood, what could be a role of palliative care in flood? And before I come to my last slide after this, even it was a proud moment to see that palliative care activity which was done during the floods was which came in the Lancet World Report. So of the World Report, and this was a pharmacy, this was the packages that we were doing, and this was a palliative care activity. The next week after the 15th, this is the next Sunday, the very first Sunday after 15th, we called upon all the palliative care nurses. They what they did was a marvelous job because on all the camps which were set up, we had ASHA workers and palliative care nurses who took care of all the palliative care patients who had to be shifted from their home. We had many NGOs like Tunnel who were completely devoted to rescuing, prioritizing palliative care patients because we know how it is hard to shift a bedbound patient. And basic only a basic training was needed in terms of post-traumatic stress disorder because the communication skills, everything, the know-how of the area, the rapport with the patients were already established by a community nurses for a long period of time. The only thing that they need to be taught is what to look for in terms of flood or regarding the traumatic post-traumatic stress disorder. Rest all were taken care of them, and these were the home cares that were happening during the floods. So our nurses would go in boats and make sure that all the long-term patients who are on long-term care are taken care of, even though they are not registered with palliative care or anything. All the long-term patients, we were providing them with medicines. We had with Pallium India had supported us during those days. I still remember Johnson coming there, and we had a list of people who had been disrupted, had the chemotherapy been disrupted, who had their dialysis being stopped due to flood because of the transportation issues. There were many hospitals were branched where they were taking dialysis. Chemotherapy was stopped, radiation was stopped. So all this was taken care of. And the marvelous thing about beyond giving all this treatment was when these nurses visited these homes, people had someone to talk to. They got someone who could listen to their grief of the difficulty of losing their home. Because we all know whatever said and done, evening we have a home to go to. And when we have lost it overnight, it is not at all uh, believable thing. So that was a key role played by our palliative care nurses. And we had an app device to make sure that the further care is followed up. We had MEHEC and our district mental health program to support the post-traumatic stress disorder. We had Pallium Indian Enhance and many NGOs coming in, volunteer students coming in, and lot of public awareness regarding post-traumatic, especially on patients who already have psychological distress. And this was a small data that was collected by our nurses, and they had visited close to 10,000 homes during that period. And they identified there are around, out of this 10,000, around 5,000 had people with long-term illnesses, out of which 72 had people with children with long-term illnesses, and 450, almost 10% of them had post-traumatic initial signs, out of which 136 people had already been diagnosed as psychiatric illness. So they are very much prone for suicide and various things. And we had around 74, we identified 74 patients who have stopped their medications, not in terms of medicines alone, but in terms of treatment, like as I told earlier, dialysis, chemotherapy, radiation, etc. And the last one, communicable diseases, we had a separate surveillance team looking after the uh, 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 communicable diseases because, again, leptospirosis was something which we were very much concerned about, and doxycycline and water purification was done. And this was the report that I was talking about. And this is one of our community nurses who, and I still remember our nurses coming till. and telling that they were not much appreciated by the health administration of one, because as we all know, always palliative care is a silent workforce and we work very silently. But then when this report came, it overthrew everything. And the psychological support that was given during Kerala floods by our community nurses was beyond words. And this is one of our nurses who is smiling with her patient. So we had many post flood. We had many, as I told earlier, we had many camps, as well as we had separate 5 clinics by in just flood affected areas. We are also Pariksha, any social workers and students came in to give support. And this again, as I told earlier, these are the photos from this is just outside my house after the flood. And this is a nearby house. This was the situation when we visited there. So after that, this was a photo that was taken during one of the camps when our river is very much silent. So these are the things that we faced during the flood. And regarding Nipah, I guess we didn't have much of in terms of palliative care, but uh, majorly from flood and from COVID. What I would like to emphasize to everyone is that the basic concept of palliative care that has been light in moving forward, and the concept of total care, like thinking of empathy and thinking of them with the amount of empathy and sympathy that we need to deliver care. Basically, everything concludes the fact that the basis of palliative care is the reason that me personally could be able to do something during this uh, pandemic as well as this disaster. So I would like to encourage everyone just to follow your heart and be able to rise up to the occasion. And I would like to give all the credit that we were able to do to our system as well as a family, because I still remember when the COVID situation came, my mother told me, "We'll consider that you have gone to US. So if you have gone to US, I can only see you once in a year. So I'll consider the same as now. So you can go and do your work." So that kind of support when you get from your family, from my wife and everyone, and the portfolio or the situation and the empowerment that we get from a health administration gave us this opportunity to deliver care. So thank you everyone. I hope it was not boring because it's mainly, as I emphasize again and again, it's mainly my personal account rather than a theoretical, where it's usually the disaster management is, as you saw on that slide, rescue, then relief, then rehabilitation. But the ground level reality was that in my term. If you have any questions or any suggestions,
Thank you, sir. Thank you so much for that wonderful presentation. I hope now many of our participants got a very clear idea regarding Kerala floods 2018 and the efforts you have put forwarded. So thank you, sir. Thank you so much for that. So now it's open. The floor is open for all, and you can ask your doubts and comment your suggestions.
I have, I think, in the chat box, what to thank you very much now, a lot of.
So there is
So regarding the first question regarding the Delta virus mucormycosis, Nipah and Zika, yes, we are as described by UNESCO. It has a lot to do with the climatic changes and the humanitarian things that we are doing to this world, that we have been faced with lot of viruses and pandemics, and we have to be prepared in terms of getting hit by more and more disasters. So regarding mucormycosis, early detection is the key, and we need not be too much worried regarding mucormycosis because like one of the doctors told once, it's a case of denominator and numerator. If 1 lakh population is immunocompromised, if one person can have mucormycosis, when you immunocompromise around 20 lakh people at a time with steroids to combat COVID, you can expect 20 cases of mucormycosis. Again, Delta variant, whichever variant of vaccine COVID it may be, the protocols are quite simple. It's the same. Wear a mask, try to avoid as much as social events as possible, do social distancing, and try to maintain uh, uh, hygiene. And Nipah virus and Zika, again, we have fortunate on having good clinical doctors who could early identify these viruses so that we could contain them earlier on. So that's how we handled Nipah, and even now Zika that came in, it was diagnosed very much early in Trivandrum so that it could be contained in Trivandrum in a lot of ways before it got spread to other parts of our state. And vaccination for palliative care patients, yes, we can ask our healthcare department to start vaccinating because, as I told, initially there was a lot of stigma regarding vaccination, but now it has proven that adverse effects are very less, and if you give proper IM injection, it is very very much less, and the efficacy in terms of saving lives are more. So as I told initially, we were hesitant to give at home because if a patient dies post vaccination, it will be always attributed towards vaccine, even though the death or the morbidity might not be related to vaccine. But now, since it has been proved to the whole population, now we can safely start vaccination at home. Already, we are crossing almost 50% of the palliative patients at the moment in Kerala. So you can strongly advocate regarding giving vaccination, especially for the vulnerable. So giving vaccination household itself, it's not a big challenge for us. As I told, we have a widespread. The backbone of Kerala healthcare system is the decentralized system, and we have a lot of healthcare workers working in the field. So field workers are the key in giving vaccination. Thank you everyone for your comments. Elderly community, of course, I hope the palliative care theory part would be taken care by parameter properly. So I'm not going to emphasize on that. But yes, elderly community comes under palliative care because palliative care is a large umbrella. Though we think of it as a minority, actual palliative care is a large umbrella where all the elderly as well as like any long-term illnesses comes under palliative care. And I guess the word would have been stressed upon earlier itself, anyone with serious health related suffering. So suffering cannot be defined in terms, just in terms of physical or in terms of the disease. Anyone who is having a serious health related suffering, for example, even after TKR, after total knee replacement, if the person is having serious health related suffering due to that, he should be taken care of as a palliative care patient. And palliative care, again and again, we emphasize that it is not a separate kind of care. It is a care which needs to be given to everyone. So at least minimum for all anyone who is having a serious health related suffering. So regarding whether only the cancer patients are taken care of with palliative care is a misconception. One of the major misconceptions on palliative care was that it was only related to people who are dying. Then came the misconception that it's only for cancer. I still remember Rajawal sir and Dr. Matthew sir are talking about instances in Malappuram and Calicut when they started. Because when they started, it was mainly for cancer patients. And I still remember a sentence from a patient telling that he was a patient with severe. So sir was an accident, he was better than. So he was praying that he would get cancer so that the palliative care team would come and look at it. But I guess that whole scenario has changed over the many years. Now, any long-term patients, including psychiatry or even Post-transplant patients comes under palliative care umbrella. So triaging for palliative care patients, I wouldn't say, again, we don't need to categorize anyone as palliative care patients. When you talk about triaging, it's basically looking at their medical history as well as their psychological aspect on what type of care they want. And if you could come into a consensus on how the mainly regarding medical history, regarding the outcome of treating for COVID, and if the outcome is bad, even whether they need symptom management home or they need to be shifted for a trial of initial level of treatment. So this needs to be done on an individual level, or a blanket statement can be brought out in terms of uh, at least advocating or start talking about triaging at home. So for hospice care. So that could be done, and I guess more than hospice, what we are trying to advocate is trying to deliver care at home. I guess I have answered all the questions. Is there any more or any contributions? Because as I told, all I have experienced is three disasters, and out of which two are the only major. Nipah was a very close community and very close disaster, and we were just monitoring around 350 patients, and it was not a common issue. So if, I'm sure that other parts of India we have more number of disasters in terms of floodslide or even how we have combated COVID. So anyone wants to have any inputs on that?
So, any more comments, participants? Or any interesting experiences you want to share? You can also add that.
Yeah, good afternoon. This is Mohan Kumar.
Good afternoon.
Yes, sir. Just I want to know regarding still last 1 month there was a Kerala model which was managed well during the COVID-19 crisis, but suddenly there is a peak in Kerala. What went wrong, or is there any lessons for other states to take from that? Just want to know.
Yeah. So regarding the peak, actually, though in a number of cases we are seeing Kerala with a peak, but from the control room aspect, they're almost like uh, I'm not even looking at the day-to-day activities right now because it is running in an auto mode. And to be truthful, we are at ease right now. Though we seem with the numbers, it might seem that we are on a hike. And from a WHO perspective, from a WHO consultant, we came to know that in Kerala, the numbers are more because of the massive testing. Because as of now, we if the real number of cases compared to the number of cases who are turned positive, it is 1:5 in Kerala, but rest of the India it is 1:30. That is, if you have 1% and 100 patients positive today, actual patients who are positive are 500. But in India, if you talk about if the 1,000 patients are positive, actually the patients who are positive are 30,000. So in terms of severity of the illness, still we are not facing any crunch. All our beds are free. ICUs are free now. Oxygen beds are completely free because there were days that where we used to gamble on oxygen beds. But now it's happening in automotive, and most of our institutions, we are closing down institutions because few of the institutions that we have taken over as COVID, now we are closing down. Today, I went and closed down a major institution. We had a lot of uh, uh, what do you call shelter places that we have turned into COVID place, halls and all, auditoriums. Now we are all closing it down because the number of cases are very much less. And when you see as a total number, it might be high, but the number of patients who are becoming sick are very much less. All the hospitals, the COVID wards are becoming empty now. So I guess testing actually even today we are coming into a new theory of not even looking at the TPR, because we are trying to formulate an equation where we are trying to find the severity of the disease in terms of number of people who are getting dyspneic. Because as we told as early as possible, you have to get out of the stigma of COVID and thinking it of as a celebrity virus. So the only way out is actually to pinpoint on what it actually is bothering us with, and it is not the fact that it is bothering us with being positive. It's mainly bothering us with people becoming dyspneic or people becoming sick and die, even with the futility of medicine. So we are only concentrating on that and trying to formulate a equation where we are only closing down places, looking at the number of people who are dyspneic from the place or needing hospital admission. So in that terms, I guess now we are at ease at Kerala. So the numbers of total number of patients who are positive seem to be high.
Yeah, thank you, sir. Continuing to that question,
Yeah.
can we say it is still in the Kerala is in a second wave or it is a third wave?
Actually, from a field perspective, I'm not a bureaucrat or a public health expert, but from the field perspective, I would say we are never out of the second wave because it was the lockdown that helped us contain second wave from going out of our hands. So now the lockdown has been released slowly. Then as the lockdown releases again, the cases might come up a bit, and you can call it as a second or third or fourth wave because experts say this was the third wave. So regarding the spike that we had in May, I guess it was a lockdown that brought down the cases. Now, since we are slowly releasing all the lockdowns because people have to live even with COVID. So cases we are expecting a bit of hike, but not like last time because now it's a controlled hike. Last time we were hit when we were not even bothered about COVID actually. So everyone was too free. Now everyone are a bit cautious, and all the restrictions are still in place, and only the complete lockdown has been shifted. So I believe that second wave is still continuing, and naming any wave I don't think really matters in the field for us. Thank you.
Thank you, sir.
Rajashmi, I guess there are no more questions.
So thank you, sir. Thank you so much for coming. And I guess
Thank,
no more comments or questions are there. Sir, it was really an interesting session. Thank you so much once again.
thank you. Thank you for having me. Thank you for having met everyone. So again, in this palliative care group, which actually is even small now in India, we might be crossing paths again. I hope. Thank you.
Thank you, sir. So thank you all. We'll be sharing the feedback form in the WhatsApp group. So see you all next class. Thank you. Thank you so much.
Thank you. Thank you, one and all.